And then, talking about the true consequences of diversion, right? Docs especially, we do not like when patients use their meds for things we don't want them to, or even use them differently. And I know no one in this room has manipulated any of their meds ever, including antibiotics. You might say, yeah, I took all those, and you didn't really take all of them. You took half of them and you got better, and then you stopped taking them, right? I did that last year in January. So, the true consequence of diversion of buprenorphine, is there a real problem with it? Absolutely. Diversion of buprenorphine means it's more available for people to continue the cycle of opiate use, right? Go into withdrawal, use buprenorphine for a while, go off of it, use heroin again, right? So that's real. However, it also means that more buprenorphine on the street means there's less overdose. And this has been shown in studies. There was one French study that showed that among the population that they were giving buprenorphine to, 20% of it was diverted. It's a lot. Makes me wonder how they were controlling it, but whatever. But their overdose rate went down by 55%. So, I'm not saying we flood the streets with Suboxone. That's not the solution for the overdose problem. But it does mean that what are the real consequences of Suboxone being more available on the street? And the truth is, it's not like we're flooding it with heroin. It's not the same thing. So for patient level barriers, this is really about education. It's over and over and over again. And I'm going to talk about some ways we do it at Sunspire. And then cheerleading. And this concludes for staff and patients. Just saying, yeah, there's doubts, and there's worries, and there's concerns, and you address them. You don't ignore them. You don't poo-poo them. You talk about them. That's part of recovery, is learning how to be comfortable with the recovery method you've chosen. All right, so I came to Sunspire Health in 2014. I was their first chief medical officer. We had 6 residential treatment facilities at that point, since about 2010. We had MDs in place at all the facilities. There were psychiatrists at only 4 of them, and there were sort of minimal hours. And when I kind of went around to all the sites around the country, I got a lot of varying opinions about MAT, from, yep, it's great, to what are you talking about, to overtly hostile. So I'm going to talk about some of the things that we did. I sort of feel bad doing this because it makes it sound like we've got it all figured out, and we don't. It's sort of like flying the airplane while you're building it. But we're still in the air, so that's good. We've made mistakes. I've made mistakes. We've tried things and they haven't worked, and that's part of building new programs. The one thing I did before taking the job is I made sure that upper management was comfortable with MAT being our primary mode of treatment, because I didn't want to join a place that wasn't what they wanted to do, and they did. I met with all the docs to find out what they thought about MAT. And also that I wanted all the docs to be willing to work with the team. There's no way that MAT works if it's siloed. If it's the doc comes in, sees patients, goes home, they never talk about, they're not in treatment team, that doesn't work. And they also needed to accept that role of cheerleader for MAT, because the doc needs to be the one that knows the information, can talk about the pros and cons, because there are pros and cons. And then talk to them all about PCS-MAT, because some of them, they benefited from having that expert to call when they were worried about something going on with a patient who was on a particular med. And then I met with all the staff. I heard a lot of concerns. These are direct quotes. We're going to be a Suboxone mill. We're going to lose the support of alumni and referrents. That's true. I was at Hazelden when they brought on Core 12, and there were a variety of referrents who said, we'll never refer to you again. Patient's going to steal Suboxone from the nursing station. That's less true. If that happens, it's a problem of the nurses, not the patients. And then I did a lot of cheerleading. I mean, I'm not a great door-to-door salesman, but I kind of took that role on a little bit. And I just sort of affirmed that we were going to do it. You know, there was a healthy discussion and addressing concerns, but it wasn't maybe we will, maybe we won't. I had to make some personnel changes with the MDs who didn't agree. I didn't like doing that, but it had to happen or it wasn't going to work. Because if the MD isn't on board, not going to happen. And then I still interview all of the docs who join us to make sure that they're in relative agreement with MAT. Now, I'll say, across our 10 sites, and my staff can speak to this, there are varying attitudes about it. It's not like everyone's in lockstep and think we should definitely do it this way every time. That's just not true. We have some that are more conservative, some that are less, and that's okay. But a general philosophy about it needs to be there. I was more involved with the selection of nursing directors sort of at the beginning. I don't do that as much anymore, and that's largely because our medical directors and executive directors are on board, so I don't really need to be. And then again, executive directors, you know, they know that they need to make sure that the people they hire, from drivers and techs all the way up to their docs, have got to be people who are on board with this to a reasonable degree. And then the big thing is training. You know, I've met and trained with all our executive directors, clinical directors, medical directors, multiple times in the past 2 years. Went to our call center, trained them on it. And then worked to make sure that our clinical directors make sure that all of our other employees receive good training on it. Now that's something that's one of those building the airplane while we're flying it things. We need to make that more accessible. It needs to be probably web-based so that people can access it when they need it. And that's something we're working on. And then, you know, standardized training modules for different job titles. So the driver, the tech doesn't need to know the same thing as the clinical director, primary counselor, nurse, right? You have to tailor it, because if you just throw the same information to everyone, it doesn't work. Electronic medical record, we are still trudging through our electronic medical record, but we've put in place in those notes that our clinicians write specific sort of prompts to say, well, did you talk to the patient about this part of medication-assisted treatment? So they have to check it. So it's a constant prompt and reminder. And we're going to give, you know, feedback on the compliance with these conversations. Engagement with industry. This, you know, coming from med school and residency is like, oh, it's drug reps, can't talk to them. And of course, we need to be thoughtful and professional about that. Especially in the case of Vivitrol, I can say that Alkermes has been really supportive and really helpful to us in helping us streamline how we can get Vivitrol in an effective way. It's not easy to do. Anyone who's tried to get Vivitrol for patients knows it's not an easy process. It can be made easier if you'll let Alkermes help you. And they can also help provide samples, which can, if there's a delay, someone's going out the door of your residential treatment and they're not going to get the Vivitrol before they leave, they can usually help with that. And then there's a lot of national databases that have providers who are MAT friendly. A warning about those is it doesn't mean you should just pick one off the list. You should find out how they do it. I've definitely had people on there, especially with Suboxone, who, you know, they're into the 30 days of Suboxone and we'll see you in a month, and that doesn't work. We've really tried to engage with insurance companies. You know, we aggressively market ourselves as an MAT provider. What we've tried to ask them to do, which I can't say they've been very helpful with, is to help us with data. You know, a lot of times we get asked by insurance companies, you know, well, what's your data for recidivism, right? How many people come back? How many people take their meds? And I always just sort of shake my head when I hear that, because they know that already. They're the ones that get the claims for the meds. They're the ones that get the claims if they go to the ER because they overdosed, or they go to another treatment center that's not ours. So, you know, what they're asking for is the data for people that we call and say, hey, how are you doing? Which is great, and we try and do that. Of course, you know, you're only going to reach about 50% of those people, and the 50% who don't pick up the phone, one has to assume that they're not doing very well, right? So our relapse rate for people who pick up the phone is fantastic, which I'm sure is true for most people. So it's not real data. It's not really useful. And it would be great if insurance companies would partner with us and say, well, let's look at the past 3 months of this patient who discharged. Do you guys have any claims for them for anything? Does it look like they filled their medication? Because if they filled their medication and there's no claims for any ER visits or anything like that, well, even if they don't answer the phone, we can at least say, well, that person at least, we don't think they're doing so badly. We haven't gotten that yet. I hope we do. So I'm going to give you a few examples of what we do at Sunspire in terms of trying to educate patients and staff. I'm not going to read all of this, but this is part of the presentation I'll give. We know that in the 90s there was a huge increase in opiate use, obviously. So we talk about that. Treatment admission rates went up 348% between 2001 and 2011. I show these nice maps which show prescription opiate use from 2001 to 2011. Red is bad, by the way. So that's not subtle. And you compare that to other things like cocaine, methamphetamine, which in the mid-2000s was a big scourge, but actually is getting a lot better, except for my home state of Oregon, where meth continues to be quite popular. Marijuana, about the same. I think we can all guess where this is going to go over the next few years, but heroin actually, by 2011 was pretty stable. Obviously, we all know that that is ticking up. I usually will cite this study for those who haven't looked at this. I think it's very helpful. This is in JAMA in 2000, so it's actually a pretty old study now. But it talks about substance use disorders and compares them to diabetes, hypertension, and asthma. So it talks about why, addictive disorders should be viewed as a chronic illness. They have the same genetic heritability, roughly, as these other diseases. The diagnoses are valid and reliable, meaning if you diagnose someone with a substance use disorder, they're probably using drugs. And if you put someone with a substance use disorder in front of 10 docs, all 10 are going to tell you they're using. And then as we talked about earlier, treatment outcomes for substance use disorders are actually not as bad as everyone thinks. They're actually pretty similar to diabetes, to asthma, and the rate of people who actually adhere to the lifestyle changes that docs and other counselors recommend, it's about the same. So it's hard to take care of a chronic illness. I'm sure there are people in this room who have other chronic illnesses. It's not easy to do. It's hard to do that consistently every day. And especially if you're young, which many of our patients are. So and then we talk about our position on MAT. SAMHSA and NIDA have said that MAT should be offered to patients with opiate disorders on a routine basis. This seems a little wishy-washy to me. I don't know why they say that, but we think it should be the standard of care given the high mortality and relapse rate. But of course, the ultimate decision whether to use medications comes down to the patient and the treatment team. So there's no prescribing of one must be on Suboxone when they leave or one must be on Vivitrol when they leave. It's up to the patient and the treatment team. I then talk about indications for Vivitrol or naltrexone. So people who haven't had success trying buprenorphine or methadone, people who are highly motivated to get off of opiates. I think it's always a question of what that means, but anyway, people who don't want to be on an agonist like buprenorphine, people who are in programs like physicians, pilots that are in a medication monitoring program but they really can't be on Suboxone. People who are already abstinent. There's no reason for someone who's been abstinent for a long period of time to then put them on buprenorphine. I do see this. I remember I had a kid, he was in his early 20s, and he kind of fooled around with Vicodin and oxys and off and on, and then he had this particular period where he used pretty heavily for about a month, then he stopped for about 2 or 3 weeks. Or no, it was longer than that. It was a couple months. And he went into his doc and he said, I'm worried about this, which is good. I'm glad he did that. And the doc said, we should put you on buprenorphine. And then he'd been on it for 3 years, and he was coming to me saying, I'd really like to get off this stuff. And I said, okay, we'll do it. But it was just unfortunate that he got thrown on it initially when naltrexone, Vivitrol would have been a better choice. And then there's some genotyping that can identify patients who might particularly benefit from naltrexone. This is a very easy cheek swab test. You send it in. I think it costs I think it's about $300. It's once in a lifetime. You never have to get it again. So most insurance companies pay for it. And this can help if someone's sort of vacillating on Vivitrol. If you show them, hey, look, your profile suggests that you're really going to react to this well. You should do this. I've definitely had that help for some patients. There's some contraindications, of course. People who've tried full withdrawal and just haven't been able to tolerate it. People whose psychiatric symptoms get worse. People with chronic pain. People who have advanced liver disease. So this is our sort of workflow for Vivitrol. At our call center, they get information about our MAT philosophy. We don't expect they're going to remember any of it, but we want to start the process. We don't promise they're going to get specific meds, so we will get people to call up and say, I definitely want to be on buprenorphine, and we'll say, well, that's nice. I'm glad you're thinking about it, but you have to be willing to talk to our doc and discuss options. We do not guarantee you will be on any med, and we don't do that with any med, frankly. We wouldn't do that with any med. The intake nurse discusses options with them and encourages them to ask questions of the physician. And they see our doc and detox. They discuss it in an informed consent manner. If they're appropriate for Vivitrol and agreeable after an informed consent, we start the paperwork. That's important because Vivitrol you can't just order it at the pharmacy and it'll show up the next day. It's a process, especially if you're going to have touch points. The patient enrollment form with Alkermes provide financial assistance. So you got to get that going as soon as possible. It doesn't mean they have to do it. It doesn't mean that 2 weeks or later, when it's all ready, that the patient now has to get the shot. They have to buy it. It just means it's all ready so that they can do it if they want. And then when they meet with their counselor, the counselor asks them about, so I know you've talked to our doc and our nurse about MAT, what do you think? And again, if they want to move forward, we get the informed consent signed and they immediately tell our medical staff and we get it going. So if they have a psychiatric visit, which most of our patients do, go over those again. Again, we take the opportunity to sign informed consent if they're ready to do that. We have group education by our MDs about every 2 weeks. That varies a little bit based on site. We talk about it in groups, so it's not off limits if people want to bring up, well, why aren't we all on Suboxone? That's a fair question. Let's talk about it. Why is this person on that and that person on this? And so we talk about those things. We have specific assigned personnel at each facility to keep track of Vivitrol and where they're at in the acquisition process. Again, this is a work in progress. It's never totally, purely a clean process, but I know at our facility, especially in Oregon, we have a discharge coordinator who's just really dedicated to it, and she is on the ball and it makes it happen. It's great. We work with Alkermes and the reps to help us. If we're having trouble getting Vivitrol because there's a pharmacy that it takes forever for them to get it or whatever else, they're right on it. That's very helpful. We have convinced our docs to prescribe Vivitrol with refills. One of the biggest dangers with Vivitrol, as many of you know, is that if you go off Vivitrol, you are much more likely to overdose and die. There is definitely a peak of overdose deaths after people stop Vivitrol, and that's because your tolerance is down. And sadly, that can happen a lot of times because docs will only give the shot and then say, well, you got to find a Vivitrol provider when you get out. Well, our patients are like all of us with medical stuff. It's not always our first priority, and on top of that, it's not easy to find someone who will do it. Now, we try and help with that so that when they leave, they already have someone set out. But even then, things happen. So we want to make sure it's not hard for them to get it. Talk about Suboxone maintenance, and again, when I say Suboxone maintenance, I don't mean we want patients on it for the rest of their lives. But we do have some patients, and this is a relatively few number of the patients we treat who it makes sense for them to be on it for longer periods. These are the people we generally think about. Multiple overdoses while engaged in a solid recovery program, including a trial of Vivitrol. So if someone has tried Vivitrol, they've tried to get off opiates, and they just can't do it, and they keep overdosing, and they're going to die if we don't do something. That's a really good patient for Suboxone. Significant periods of sobriety while on Suboxone. So they've been on Suboxone, they do well, they go off, they relapse. They go back on Suboxone, they do well, they go off, they relapse. that's someone who should probably be on it for a longer period. Doesn't mean forever, but a longer period. People who are abstinent from opiates on Suboxone but are struggling with another addictive disorder. We had a patient who came in recently. He's been on a stable dose, I think 6 milligrams of Suboxone. Went through a divorce, started drinking heavily. So a lot of places would say, well, you got to get you off Suboxone, which to me makes no sense. If someone is doing well, they haven't used opiates for years, they picked up drinking, let's worry about their drinking. Let's leave the opiates alone. Seems to be doing pretty well. The caveat here is if they come in with a benzo disorder, right? So if someone's using benzos and they're taking Suboxone, that's a different story. That's contraindicated and quite dangerous. So there are individual cases. Patients with pain syndromes for whom Suboxone has been really effective. We had another lady who came in who, how she got on Suboxone for this is confusing to me, but she was on it for chronic headaches. Long history, she had been on every migraine medication under the sun. She had vagal nerve stimulation. She had an implant. I mean, this woman had been through every possible treatment for migraines, and somehow she ended up getting on Suboxone and had a history of alcoholism, but never anything else, and headaches went away. She was on 2 milligrams, I think. She started drinking after some stressor that I can't remember right now, and our staff was sort of like, well, so do we take her off Suboxone? She actually wanted to try coming off. Took her off of it, headaches came roaring back, and we said, you know what? That's working for you, let's leave it on there, let's address your drinking. We need the patient to be involved in the decision process, need to explain the options clearly and get the family involved when that's appropriate. And then this is the biggest one, and this is why we don't do more Suboxone maintenance, frankly, is that they're trying to find a provider who does it well is not easy, as many of you know. It's very difficult to find someone who's going to prescribe it and require that the patient also be involved in a real treatment program. So not just showing up every month and getting a prescription, doing pill counts, doing urine toxes, in therapy, in counseling, going to self-help, that sort of stuff. Challenges, we're constantly having to re-educate staff. Then the appropriate outpatient referrals is a big one. Trying to get payers to reimburse. And we do need outcomes data. I would like to have more of that. We do a lot of it, but we need more. That's about it. I'll stop there. I'll just say in the end that I think to be able to do MAT well, it has to be, as I've tried to describe here, a thought out, methodical process. It is not something that you can just sort of slap on and say, start doing it, because it is a big philosophy change in a lot of cases, and it is difficult. It requires a lot of coordination between multiple parts of the treatment team to make work well. If you don't have that, you end up with patients being frustrated because they've been told one thing and they're not getting it, staff being frustrated because they're not sure, well, why do I do this in this case and not the other? And it ends up hurting more than it helps. If you do it well, it helps a lot. And I'll leave it at that. Thank you.